I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. Thank you all for joining us, hopefully in your cozy living room at home, wherever you may be in the world. We are so happy to have you all tonight. As many of you know, tonight's discussions are going to be around new biomarkers, new therapies, and the importance of knowing your cancer. I know those of you who are veterans to GoTo Foundation and especially the living room, you know how we talk all the time about how important it is to know your cancer. So for those of you who might be new, we hope you learn a little something about why we think that's so important tonight. I'm very pleased to have Dr. Benjamin Levy from Johns Hopkins Sibley Memorial Hospital joining us for the discussion tonight. And for those of you who may notice that other lady there on the screen, our very own Bonnie Adario is back and in action at the living room with us. So we're thrilled to have her back as well. Before we jump into the conversation, I want to let everybody know, you may or may not know, California has been having some heat waves and some fires, and due to that, there are rolling blackouts. We don't know if or when that is going to happen, but if it does, we're sorry, and we will have to continue it later. We just wanted to give you guys that heads up in the event that the power did go out and the feed was lost. So before I get started, Mom, I don't know if you want to say hello to everybody. It's been a while.
Just hi, everybody. I could not be here. I just adore this physician that's going to be teaching us many great things tonight, and miss all of you.
Thanks, Mom. And before we jump into it, typically historically, those of you, again, who have been watching know that I would introduce our speaker by reading a very long bio that didn't come across as very personal. So I'm going to ask Dr. Levy if he wouldn't mind telling us a little bit about himself, why he chose lung cancer to become one of his areas of expertise.
Hello, can you hear me?
Yeah.
Yes.
Yeah.
All right. I lost you for a second there. So I don't know what you said, but let me just start by saying thanks for having me, Danielle. Thanks, Bonnie, for having me. It's a wonderful opportunity to be in the living room again, this time virtually. So very excited to be here, and I look forward to answering questions. And I have an interest in targeted therapies, and this will be somewhat of the topic discussion tonight, so I very much look forward to it.
That's awesome. What I was saying when unfortunately your audio went out was, rather than me reading a long, boring sort of bio, not that your bio is boring, but will you tell us a little bit about why lung cancer is important to you, why you chose this area to be an area of focus for you?
Yeah, I think that, first of all, the patients, having the experience with the patients with lung cancer has been second to none. Prior to doing lung cancer, I was in the field of GU cancer, believe it or not, for a couple of years, and shifted over to lung cancer. And it was such a different experience connecting with these patients. I think the more important is just as important, excuse me, is the science. There's been tremendous advances in the field that have made this so exciting to take care of patients. Whereas 10 years ago, we were saying to patients, look, we have chemotherapy and that's it. And now we're talking about 25, 30 different therapy options for patients. It's an incredible ride that we've been on here, and the science is extraordinary. And it's been a win and exciting for physicians, but more important, it's been a win for patients. And that's why it's such a pleasure to be in the field right now.
Thank you so much for that. I know it means the world to not only your patients, but to patients out there who get to hear you speak tonight. So thank you. With that, we're going to jump right in. These are fast and furious. We only dedicate or have an hour to dedicate to this meeting as opposed to our regular 2-hour meeting. So with that, we're going to take a deeper dive into biomarker testing. We're going to focus a little bit on some of the lesser known biomarkers. But before we jump into that, I want to ask you, Dr. Levy, what exactly is a biomarker? What does that mean?
Yeah, in general, a biomarker is any feature of the tumor that allows us to better tailor and select therapies. And biomarkers in this day and age are most commonly, when we talk about biomarkers, we're talking a lot of the times about the genomic features of a tumor, the genetic makeup of the tumor, the DNA underpinnings of the tumor. And what we've learned over the past 5-10 years, right when I started in the field 11 years ago, is that there are a list now of particular genes in cancer, and lung cancer specifically, that if you have a particular gene, you can get a tailored therapy to that gene. And that really is, when we talk about biomarkers, that's what we're most of the time, not all the time, but most of the time when we talk about biomarkers in lung cancer, that's what we're talking about. We're talking about genetic alterations or genes in the lung cancer. These are not genes you're born with. These are genes only in the lung cancer that if you identify them in a cancer, you can potentially offer a patient a tailored, personalized treatment, oftentimes in the form of oral therapies. These are called targeted therapies. And so that's the general meaning of biomarkers in lung cancer. And there's different ways, I know we'll talk about different ways that we can try to identify these genes in lung cancer. But that's the general lingo. Biomarkers is most of the time referring to genetic alterations in the lung cancer.
Yeah, that's great. And I love that, the sort of the general, because I know that quite often patients are confused when they call our helpline or we're talking to them and we ask them if they've had biomarker testing and they're like, no, but I've had molecular testing, or no, but I've had genetic testing, right? So it is a diagnostic test that goes by many names, which can be confusing. So thank you for pointing that out. So when we're talking about biomarker testing, who should get this testing?
Yeah, this is if you would have asked me this maybe even 2 years ago, my answer would be different, which is just so emblematic of the pace of discovery for lung cancer. This day and age, every patient with lung cancer, non-small cell lung cancer, which is about 85% of all lung cancer, is non-small. That's the most common type we see. And within non-small cell, there's two subtypes. There's adenocarcinoma and there's squamous cell carcinoma. And all patients with adenocarcinoma should receive genetic testing or genomic profiling of their tumor. For squamous cell, I would say that the jury's still out whether all squamous cell patients should receive molecular testing, but any patient which is a squamous cell where they either are a remote smoker or former smoker or not a current smoker, those patients should also be genetically tested or have their tumor molecularly profiled. I think that we'll learn more about genomic alterations or genetic features within squamous cell, because it hasn't really been the same for the squamous cell as it has been for adenocarcinoma. So general rule, long story short, how I summarize that answer is I say I test everyone except for heavy smoking squamous cell patients, but that may change over the next year when we begin to identify additional targets specifically in squamous cell that justifies the routine testing for this subtype of non-small cell lung cancer. The second thing I want to say is that, and we'll talk about this, there's a lot of controversies on should all stages be tested. Should advanced stage patients be tested? Should early stage patients be tested? And we'll talk about some of the relevance and new data that's come out. But every one of our patients at our center gets tested irrespective of stage. So, I mean, that's a broad group of patients and that's a broad panel. But that is generally the initiative that we try to institute, because the rule of thumb is test, don't guess. And so we really have to know the genomic underpinnings before we make treatment decisions for patients.
That's great. I think that's really important. And I think I noticed that Bonnie might have had a comment there, but before we go to her comment on this, when we talk about biomarker testing and genetic alterations, how is that different? And I know we talk about that general, to your point, in the realm of the non-small cell lung cancer patient, adeno or squamous. But when we're talking about PD-1 or PD-L1, how is that different? Is it different? Yeah. And what sort of group does that look at?
It's a great question. So backing up in terms of what truly is a biomarker, when patients walk through the room, I tell them there's two sets of biomarkers that we routinely look at when patients walk through the door. The first is the molecular testing that I mentioned. And this is, again, to identify certain genes that may be in the tissue of the lung cancer that may help tailor our therapy. And that is really looking at the DNA of the tumor. And the second thing we look at, our second category, is what's called a PD-L1. Now, PD-L1 is not a gene, it's a protein that's expressed on top of the cell. And so I always, when patients come in, I draw this out and I say the DNA is inside the cell and we're looking and testing that. But we're also looking at the protein expression of this particular protein, PD-L1. And that's important, because if patients have a PD-L1 protein expression of a certain degree, they may, usually 50%, they may qualify for immunotherapy. Where things get very tricky is that oftentimes patients may have a gene of interest, which would allow you to give a targeted therapy, but they also have protein expression that would allow them to get immunotherapy. And those are two different classes of drugs. And generally, the rule of thumb in our clinic and hopefully across the country is that the gene supersedes the protein when it comes to decision making. So you always want to rely on the genetic testing first. That should guide your treatment and really take precedent over the PD-L1. But when we're talking about biomarkers, we're talking about the genomics, the DNA, but we're also talking about the protein expression of PD-L1. And those are the two categories we look at when patients come through the door.
And I think it's so important when we talk about the immunotherapy space, particularly when it comes to small cell patients, right? Because recently there were approvals in that space, and fairly recently now, it's been a bit. And that's the first new approval for small cell patients in forever, right? So it's really years. Exciting. Right. Yeah.
Very exciting.
Yeah. I thought maybe we lost you. You're there, Mom?
I'm here.
Yes.
And Mom, everybody's there. Okay. Any other comments about that before we move on to what is the difference between a limited and comprehensive panel?
You know, I would like to hear what Ben has to say about these submarkers. You know, you can be an EGFR exon 20 or exon 19 or 18 that can change the program that you put the patient on as well, right? How can we really explain to patients in the simplest form, you know, what to ask for, because 80% of patients are seen in the community, and not everyone in the community is as knowledgeable as you are. How do we get to the patient to easily ask and make sure they're getting all of the right testing?
Such a great question. How long do I have?
You have as long as you need.
So, so let me, we'll get to Danielle's question about limited and comprehensive testing, but you bring up a good, so, the point is you're supposed to test all genetic alterations or all genes, and we'll talk about that in a second. But what's confusing, and this is not just restricted to EGFR, but certain genes have subtypes. So not all EGFR mutations are the same. So when you see this common EGFR mutation that's in your tumor, which will allow you to receive a targeted therapy, you actually have to look at the type of EGFR mutation it is, and understand that some EGFR mutations allow you to tailor the therapy to one particular targeted therapy. And some EGFR mutations may mean that you can't give the targeted therapy, or that they may be resistant. And this goes for other types of mutations as well. We'll talk about KRAS, but not, KRAS is yet another mutation that may have an oral targeted therapy that is restricted to something called KRAS G12C. It's not all KRAS mutations, but specifically for KRAS G12C. So EGFR mutations have led the way with personalized therapies. They are the beginning story. They're chapter 1 of molecular testing for advanced non-small cell lung cancer. But what we've learned is not all the EGFR mutations are the same. So what I tell patients is, be sure to ask your physician, what molecular testing is being done, and then also what subtype of mutation they have. So if the physician says you have an EGFR mutation, the patient should ask, well, which type? And I think that's important. I also think it's important that the patient, as complicated as the report may be, get their hands on the report and take a look at it so that they can see. It's a very complex field. And even academic physicians are still wrestling with some of the complexity, but it's a call for patients to be their own best advocate, to say, I always tell patients, ask what type of mutation you have, not only just the general mutation, but the subtype of mutation, so that they're aware of it and that they can maybe look into what would be the particular therapy. Because again, some EGFR mutations will allow you to give targeted therapy. Some maybe a certain targeted therapy may work over others. Like exon 20, we have potentially a new therapy that may be available. Some exon 20 mutations that are EGFR are not sensitive to any targeted treatment. So it's very complex.
Yeah.
One of the things that you touched on that I think is so important, and I know we preach about this all the time, is ask for copies of your results. And they are complicated and quite often not easy for, to your point, even a physician to understand. And I'm gonna plug GoTo for a second and just remind folks out there that even if you ask for these, and if you're concerned about calling your physician or really not getting the detailed information that you want, through our helpline and our Lung Match program, we have trained navigators on board that will walk you through in very simple terms, what the results of those what that test means. We kind of see ourselves as a complementary addition to what you may or may not be getting from your physician's office. So please don't hesitate to reach out to us for that. And I know we were going to jump into limited and comprehensive, but we did get a question from online saying thank you for discussing genetic testing and recommendations for non-small cell patients. But what are the current thoughts on testing small cell patients, and or what type of research is being done in that area?
Yeah, this is just evolving right now in terms of genetic features of small cell. We're just beginning to scratch the surface. And I will tell you, for now, it is not prime time to order routine genetic testing on small cell. We don't yet have the therapies available for patients with small cell, but that doesn't mean that we won't someday. And there's a tremendous amount of research going into this. Small cell may be some new research would suggest that small cell may be divided into 4 distinct molecular subtypes. Whether those 4 distinct molecular subtypes drive particular therapeutic decision-making is still being looked at. I look forward to the day that we have genetic testing routinely for small cell, but right now we don't routinely use it in our clinic. But I hope the day comes soon where we do.
Yeah, and I think that points back to, the importance of patients researching and looking into clinical trials, right? Because that's where
Absolutely.
you said earlier, you said earlier in this conversation, what I'm telling you now is different than what I would have said 2 years ago about who we're testing and what we're testing for, because that is consistently evolving because of patients like you participating in these trials. So
that's a call.
Please have those. Yeah. And I encourage patients to have conversations with their physicians about it. And again, our navigators are able to help kind of navigate clinicaltrials.gov for you based on your treatment history. Mom, you had something you want to say?
And I did, and we're also big proponents of telling patients about getting a second opinion, because very often, they can get a second opinion with someone like yourself that will work with their community doc in the middle of nowhere and help guide as well to the best possible program for them.
Yeah, Bonnie, I can't tell you how many times I've been open and receptive and collaborated with community docs and said, either I have a trial or there's a trial closer to their home that they may be eligible for. We'll help them navigate clinicaltrials.gov, especially patients with small cell, where we're really working on newer therapies to advance the field. This is a time that we have to collaborate with one another to move it forward. And we have to do that scientifically, but we also have to do it clinically with our community partners.
And this is how the patient wins.
Exactly.
They have a little team here, working on them that are equally as concerned about, their longevity. So, awesome.
Okay, so now to the question. What is the difference between a limited panel and a comprehensive panel, and what should we be looking at there?
That's a great question. I think that this is probably the most critical question you've asked so far is, what's the best way to find out the genomic underpinning of the tumor? And this is one of the most fascinating, fields right now, is optimal ways to test. And I think the old way of testing for lung cancer was through what's called a limited panel, which, believe it or not, required a fair amount of tissue, a fair amount of DNA from the tissue biopsy. And it looked at just 3 or 4 genes, specifically EGFR, ALK, and ROS, sometimes KRAS. Again, these are 4 genes that are common in lung cancer. And so if you just want to look at the common genetic mutations for all lung cancer, why not just look at 4? And I think what we've learned over the past 5 years is that there's been convincing data and convincing evidence that if you do that, you will miss other mutations that would allow you to deliver targeted therapy or oral therapy. You will miss what we call actionable mutations that you can act on with a pill. And so this has changed the way we think. And over the past, I would say 5 years, we've really made a push for comprehensive genomic profiling, otherwise known as next generation sequencing. That's the buzzword. That's what you need to ask your physician. Has your tumor had next generation sequencing? It sounds like something out of Star Trek. It is not. It is what we do for every single patient that walks through the door. I'm passionate about this. I think that there are platforms, next generation sequencing platforms, that can be done internally, meaning it can be done in an academic institution. But fortunately, there are commercially available assays too that any oncologist can send their tissue out to. And this is standard of care in my mind. Every single oncologist who's treating a lung cancer patient needs to send tissue out to a next generation sequencing or comprehensive genomic profiling that can capture more than generally 300 genes. We're talking usually about 3 or 4 genes. Now we're looking at 300 genes or more. So that's really where we've moved the field, is with this comprehensive genomic profile. And we know by doing that, we should really be able to deliver the best therapy for patients, personalized therapies and targeted therapies, and capturing the genetic alterations.
Hallelujah.
That's great. Yeah.
Thank you. You're preaching to my choir.
Yeah. So when we talk about this testing, how is this testing done? Is it required on tissue? I know liquid biopsies have been a big, part of the conversation over the last several years. Is tissue still considered the gold standard? If so, when does the liquid biopsy become a relevant diagnostic?
Yet another thing that has been altered. If you would have asked me this 2 years ago or 3 years ago, I'd have a different answer. But wow, it's exciting to be in the field given that the answers are changing every month. But liquid biopsies are a critical aspect of the diagnostic algorithm for patients with lung cancer. And what this is essentially technology that can pick DNA up in the bloodstream. And what we've learned about lung cancer, and a lot of tumors for that matter, is when tumors grow, they shed cells and they shed DNA into the bloodstream. And if you have technology to do next generation sequencing, genetic testing off the tissue, you could apply that same technology if you were able to capture that same DNA that's shed from the tumor in the blood. And so we now have FDA approval just 2 weeks ago. This is how fast it's moving, to use liquid biopsies for patients with non-small cell lung cancer. And I could go on and on about liquid biopsy. So Daniel, you're going to have to just pump the brakes on me when you're ready for me to stop, because it's really where we have made such incredible strides in diagnosis for lung cancer. The bottom line is that if you just do a tissue biopsy on a patient, even in an ideal world, even in the ivory towers of academic centers, it's not a perfect system. And unfortunately, when you send that tissue off to have molecular profiling done, you're going to miss genes sometimes for many reasons. One is that you may not have procured enough tissue when you did the biopsy, even with a good interventional radiologist or our interventional pulmonologist. Two, there's something called tissue stewardship, which means that once the biopsy is taken, they cut it up into slices, and oftentimes you lose content that can be tested for. So there's a lot of reasons that even in a perfect system, when you do a biopsy, it won't always yield you all the information you need. And then if you look now, here comes liquid, and liquid can supplement the testing from tissue. It essentially is an insurance policy in my mind that you're able to capture the genetic alteration of interest that may be missed in tissue, or you may find it in tissue as well. There has been recent data, actually 2 data sets to suggest, and I'm not going to go through this in too much detail, but the bottom line is, if you look at lung cancer patients, a fair amount of lung cancer patients, and you're to do a tissue biopsy and a liquid biopsy at the same time on the patient, the first thing is, number one, the gene that you find in the blood is the same gene you find in the tissue. That happens about 90% of the time. That's intuitive because the tumor is shedding DNA in the blood. You would expect the same result from the blood test as you did the tissue test. More importantly, however, if you look at those patients who do both blood and tissue, the blood will add, it will essentially enable capture of more mutations that were missed in the tissue and increases your yield or chance of identifying that mutation. So in my mind, it's the insurance policy. And we do it on every single patient who walks through the door, every lung cancer patient who walks through the door who's had a tissue biopsy. Even if the results aren't back from that tissue biopsy as it relates to the genetic testing, we also do a liquid biopsy, a blood test. And that's for all the reasons I explained. And in addition, the results of a blood biopsy take around 5 to 7 business days. It's incredible. And you compare that to the results of how long it takes in a tissue biopsy. The results for genetic testing for tissue biopsy take around, at our center, sadly, around 28 days. So you're talking about more a rapid test. It's accurate, and it can often find mutations that were missed in tissue. Now, one small thing I want to say about blood is that blood is not perfect. While if you find a mutation in blood, it's true. There's no such thing as a false positive. And I always tell residents and fellows, blood is truth. If you find the mutation in blood, it's accurate. You can act on it. But if you don't find anything in the blood, it could still be in the tissue. So a blood test by itself is not the best way to go. You need to do both on patients, again, because we have too many genes of interest now where we can deliver targeted therapies, and we need to make sure we capture them. And if tissue is imperfect, we have another platform that can ensure, or at least aid, in the detection of some of these genes of interest.
That you explained that beautifully, and I want to just touch on a couple things because I really want to make sure that we drive this home with the folks watching live and the ones that will come back. It makes sense, I think, for most people that if you find it in the blood, it's because it's in the tumor is shedding off those tissues into the blood, and we found it. What might not make sense to a lot of folks is, I'm going to use a big word in case you hear it in your doctor's office somewhere, but heterogeneity. Can you explain what you touched on it, but can you explain it a little in a little bit more detail about what that means?
Yeah. So heterogeneity is another concept in lung cancer that's evolving, which is essentially that if the lung cancer is, let's say, a baseball, I would say that 90% of that baseball harbors the same genes. However, 15% of it or 10% of it, whatever, doesn't have the same genes. And that's what's called tumor heterogeneity, for one. So unfortunately, if the needle is that tissue biopsy that goes in is and the needle's in that 10%, you're not going to find that gene of interest because the gene is only in 90% of the cancer cells. Cancer cells are smart and complex. And you have this tumor, it's not all identical cells. We think of it as is, but we know there's some heterogeneity in there. And so that heterogeneity is sort of a hallmark of lung cancer, but unfortunately poses challenges for us because if that needle goes into the wrong place and it takes a bunch of cells, you may have hit the wrong group of cells and thus you've missed the gene. However, enter blood. The idea is that all of those cells are probably shedding DNA. And so the liquid biopsy is able to capitalize on heterogeneity and identify all the mutations, whether it was coming from the 90% or the 10%. The concept is all those cells shed into the bloodstream. So you're able to accurately capture those mutations. And that's what's, what we call, spatial heterogeneity, where we're able to capture it. The other thing that's important is that if you have a lung cancer and then you have another spot in a lymph node and maybe another small spot in the adrenal gland, technically all of those spots are going to shed DNA into the blood, and you're able to capture them by a simple blood test because, again, you're capturing everything that's shedding, which is a little different than capturing just the area where the needle was located. And that's why a blood test can capture or really encapsulate all that heterogeneity within 10 cc's of blood. Sounds like science fiction, but we're here. It's now, and it's here to stay, and it's FDA approved, and I couldn't be more excited.
That was absolutely perfect and exactly what I needed. I'm hearing the sound bites, and I already am trying to think about how else we're going to be able to use them in order to educate even more people
You can
about
invite
this.
me back. I can do it again.
I know. We already said you promised you're going to come back, especially when we can meet live again.
Or we can do a living room from John Hopkins.
Well, done.
Yeah. Right. Yeah. As soon as we're all able to travel again.
Right.
So you touched a little bit on the big three or the big four, and that's, typically what a limited test might look like. But to your point, and some of the things you said earlier, so many exciting things are happening in the lung cancer space right now. So, you mentioned EGFR, ALK, ROS1, KRAS to some degree. And we've done plenty of living rooms on that, not to discount those markers at all. But what I do want to highlight, in particular, as it sort of relates to this next generation sequencing and the importance of it, are some of the lesser known biomarkers, the ones that people aren't really talking about a lot. They may not have trickled down into even mainstream medical oncologists' office, particularly in more rural areas. But if we can educate the patients and then they can go back and have these conversations with their doctors, we kind of bring that top down, bottom up sort of approach to this whole biomarker testing and why it's so important. So I want to talk about some of those lesser known and HER2, MET, RET, NTRK, KRAS G12C. You brought that up a little bit ago, and then even the PIK3CA. This is something that's kind of emerging in the squamous space. So I don't know where you want to start or which one you want to start with, but talk about some of the exciting things that have been happening in that space.
Yeah, I wish we had 3 hours because the list gets longer every day in terms of, I mean, we've had something on the order of 5 or 6 drug approvals in lung cancer in the past 6 months. So it's just insane. Yeah, as you mentioned, EGFR mutations and ALK rearrangements and ROS rearrangements were sort of the leading edge. They were, like I said, chapter 1, 2, and 3 of molecular profiling in lung cancer. And, if you would have asked me how many chapters are going to be in this book 5 years ago, I would have said maybe 4 or maybe 5, And as you've mentioned, that we are now learning more and more about other mutations outside of just EGFR, ALK, and ROS that can be identified in lung cancer and can help select tailored therapies. And the nice thing about this is that the mutations are mutually exclusive. It makes it easy. If you have one, you don't have the other. So you never have 2 mutations. It's a nice story. It's a clean story. And oftentimes this is represented pictorially by a pie graph. And every slice of the pie is a different mutation. So as mentioned, EGFR, ALK, and ROS, chapter 1, 2, and 3, but we've got about 6 other chapters. Some of the more are less common, but still there. I mean, there are a lot. These are less common than EGFR, but certainly I see a ton of these patients. So looking at things like RET rearrangements. RET rearrangements are the new darling child for lung cancer. The RET rearrangements are around 1% to 2% of all lung cancer. If you can identify a RET rearranged lung cancer, we have a new drug approved called selpercatinib. It's an oral therapy. It's well tolerated. It's exquisitely can attack the tumor. It elicits responses for patients who have brain metastases, so it crosses the blood-brain barrier. And that drug is approved recently. We have another drug called pralsetinib for RET rearranged lung cancers. It's not yet approved, but also showing, again, oral therapy showing good response rates to patient oral therapy eliciting good response rates. Outside of RET, then you have other mutations called MET exon 14 skipping mutations. I'm happy to say that again, MET exon 14 skipping mutations. Yes, there's a mutation called that. And that, again, if you have a MET exon 14 skipping mutation, this is yet another mutation that has a new approved targeted therapy, a drug called capmatinib. Oral therapy, well tolerated, targets selectively against that mutation. Other mutations like NTRK fusions. NTRK fusions are an interesting story. It's a very rare in lung cancer, but we still find them. The interesting thing about NTRK fusions is that they are seen in other tumor types, and they're common in rare tumors, and they're less common or infrequent in common tumors. And the trial that basically got the drug larotrectinib approved was an interesting trial design. It was an umbrella trial design that essentially looked at NTRK fusion patients irrespective of where the tumor was, what type of tumor you had, and every patient got larotrectinib. And again, this is another approval that we have. And then 2 more that I want to mention. The first is HER2 mutation. This is a biomarker that we know is relevant in breast cancer. And we have many drugs approved in the breast cancer world that are HER2 positive, at least by a different type of assay. But HER2 mutations are now found to be relevant in lung cancer. And we had data just 5 weeks ago, 6 weeks ago, 2 months ago. So 8 weeks ago at ASCO, looking at a new drug called trastuzumab deruxtecan. It's a new class of drugs for lung cancer. It's an antibody drug conjugate. It's an infusion, but it specifically targets patients that have HER2 mutations. And again, giving this drug, it looks really good. The drugs elicit meaningful responses. They're well tolerated. And then finally, KRAS G12C. This is yet another mutation that 5-10 years ago, I would have said there is no way we're going to be able to drug this mutation for many reasons that I won't get into, but biologically, it's a very hard mutation to target. And we know that for patients with KRAS G12C, there is not yet a drug approved, but there's a drug that's moving fast, an oral therapy that can again elicit meaningful responses and really change the way that we think about KRAS mutations because they were thought to be so undruggable. So for many of these ones that I mentioned to, we have approved therapies. For HER2 mutations, trastuzumab deruxtecan is not approved yet. For KRAS G12C, the Amgen drug, Amgen 510, is not approved yet. But I think it will be in the next 6 to 12 months. And it's just a very exciting time. And I think all of this, Danielle, I think this truly underscores the importance of comprehensive genomic profiling, next generation sequencing. We cannot just get away with doing EGFR and ALK. And you just got to, I mean, I can't tell you how many second opinions I see where I look at what the genetic testing was done on the patient, and not to throw shade on any of the private practice people because they're great and they're working in the best interest of the patient. But the data is so quickly evolving, it's tough to keep up with. But I can't tell you how many patients I've had where they show me their molecular testing and I say, what else did you have done? And where's your liquid biopsy test? And unfortunately, they just had 3 genes tested, EGFR, ALK, and ROS. And you're missing 7 or 8 other genes that either have approved therapies or therapies that we have trials for. So, and the last thing I'll say, and then you can shut me up, is that the conversation of it's so hard for me to describe the difference in the conversation that goes down. It's not good or bad, but just different. The difference in the conversation that goes down when we're offering targeted therapies versus offering chemotherapy or immunotherapy. They're entirely different conversations. And we have to know this information up front so we know how to tailor that conversation the same way we're tailoring the therapy. I mean, it's a very different conversation that goes down when it's, hey, you're going to be on a pill and I'm going to see you in 2 weeks and you're going to call me and tell me how you're doing, versus, hey, you need to get a port put in and we're going to do an IV on you every 3 weeks. And I'm not saying that there's anything wrong with that, because we do that for a lot of our patients and that's okay. But I think in the end, we have to know this information and we have to do the comprehensive genomic profile. It can't just be three genes. If you learn anything tonight, just test, don't guess, get the comprehensive testing done and do next generation sequencing, both in tissue and in blood.
I mean, and I know she's like doing this and like little dances in her head crazy, right now. Right? Yeah. Like, I mean, but I think this is why, we're constantly sort of browbeating people about this testing and why it's important. And you couldn't be saying it more perfectly or eloquently. And I think there are a couple questions online. I just wanted to make this comment first. I mean, again, this points back to none of this would have happened without clinical trials. And you said something that I think points back to it is even more relevant to some degree, but that even if there's not a drug available currently or a target based on what your biomarker testing shows, there might be something in clinical trials that is showing huge promise. And that might be your best first line treatment, right? As opposed to, sitting in the infusion chair. So
yeah, and can I just say one thing about clinical trials before we move on?
Yeah.
And that, people think like, well, if I'm going to a clinical trial, I have a 50% chance of being a guinea pig. And what I tell patients is that couldn't be further from the truth. All of our trials generally don't have a placebo arm. All the trials ensure the delivery of the therapy being tested. And I just want to be very clear that, people think clinical trials are a bad word, or that you're at the end of the line, or that there are no other options. And it couldn't be further from the truth, given all the science that we've really, truly tried to leverage and all the drugs that are available. Most of the trials now are designed specifically for patients that does not involve a placebo or control arm. So you're 100% assured of getting the drug that we're testing.
Oh, that's great. Okay, I want to ask a couple of the questions that came in online while we've been chatting. The first one is, you mentioned KRAS G12C. How far away do you think we are from having a targeted therapy for that?
For KRAS G, I think the KRAS G12C, we're pretty close. I mean, the Amgen 510 drug is currently coming down pretty quick, and I think the question becomes, how far are we away from other KRAS G12Ds and others? And this gets to, again, some fascinating science, why we have a particular drug that can target KRAS G12C and not KRAS G12C. There are ongoing looks and molecule development for KRAS G12C. I think honestly, we're still probably 2-3 years away from a targeted therapy for KRAS G12D. Again, this is just a different subtype of KRAS, but I think there are evolving trials looking in the space. It's just a harder mutation to target, and if mirroring the pace of G12C, who knows how quickly we'll have a therapy for G12D.
Right. Next question. Any special considerations in terms of biomarkers for non-small cell that has transformed to small cell?
Yeah, this is a great question. We know that patients specifically with EGFR mutations, I assume this question is coming out of an EGFR patient scenario or an ALK rearranged scenario, but we know that around 10% of the time, for reasons that we can't quite explain, patients that are non-small cell adenocarcinoma, EGFR mutated, when they get treatment with a targeted therapy, their tumor can evolve into small cell. It can completely shift into a different type of lung cancer, and we're still trying to iron that out. That happens around 10% of the time. And the question is what is the optimal therapy for these patients? Unfortunately, for molecular testing, we don't really have, again, small cells tough to test for molecularly, and we don't have tailored therapies for molecularly, but there are ongoing clinical trials with some good rationale looking at potentially other types of chemotherapy or even immunotherapy for patients whose tumors evolve into small cell lung cancer. But it's a very challenging, certainly very challenging to treat, but doesn't mean that therapies don't work.
Right. Next question. Are there any correlations between where the tumor has metastasized and how well a patient responds to a specific treatment?
It's a good question. And generally, I don't think we have a lot of great data on this. And so the answer, it really is no. I think that I just had a patient had a question about this today in my clinic. Patient had a lung tumor that had metastasized to another area. And the question was, well, if you give me this targeted therapy, it's only going to work in my lung, right? And I say, no. I say, the tumor is in multiple parts of your body, but it all harbors, hopefully, the same genetic alteration that will allow this drug to work across your entire body. And we know that patients with heavy tumor burden versus those that have limited burden of disease, it doesn't change the calculus or change, patients with heavy tumor burden aren't less likely to respond to targeted therapy, and they're just as likely. And so it's just a call again, even if you have metastases in bone or in other parts of your body, you should, receive these therapies, and these therapies work wherever the tumor is: bone, lymph node, brain, lung, which are the most common sites that lung cancer can go.
Right. One more, and this is interesting because I think I know on the helpline we get this question a lot. Should targeted therapy for METC exon 14 be used when on IO, Keytruda and Alimta maintenance that is currently working? So should they switch to a targeted therapy if their IO is working?
This is such a great question, and one I get this all the time too, and I think we're still trying to learn, and I won't try to delve too much into the data because we actually have some data on this. I think for patients that, my strategy is always to I'm a targeted therapy guy, so of course I'm going to say this, but my strategy is always to give the targeted therapy first. However, patients like with exon 14 skipping mutations, the target therapies haven't been available until about 4 weeks ago. So any patient who's on a chemotherapy, immunotherapy regimen is doing well, I probably would not switch them. I would keep them on the immunotherapy, chemotherapy regimen until A, they weren't tolerating it, or B, they had experienced disease progression. And then when that happened, I would consider a targeted therapy. I think the one complicated nuance of all this, and I'm so sorry we don't have too much time for this, is that there may be some toxicity challenges when you start with immunotherapy, or a patient who's on immunotherapy who then gets targeted therapy. And there's some overlapping toxicities that can occur. And so what I do say is that you at least try to give a 2 to 4 week washout from the immunotherapy, meaning you at least wait 2 to 4 weeks, if not longer, to deliver the targeted therapy after the last dose of immunotherapy. And that's a whole nother area that's evolving in terms of the overlapping toxicities and why patients get this when they start immunotherapy and then get shifted over to targeted therapy.
It's one more thing you can talk about when you come back, right?
I'm
That's right.
planting the
That's
seed,
right.
Danielle. I'm planting the seed.
So before we jump into something that I know is particularly near and dear to Bonnie's heart, as well as the rest of ours, going back to some of the lesser known biomarkers and what we were talking about, and some of the approvals that have happened already, and some exciting things happening still in trials. Can we expect, or can our community expect, the same thing will happen in these mutations as happened previously in EGFR, ALK, and ROS1, where there are second and third generation drugs that will be coming out?
It's a great question. So the rule of thumb is always, you start with a targeted therapy, and it works really well. And unfortunately, at some point, the cancer may grow. And the question is, well, what do you do next? And this gets to the idea of understanding mechanisms of resistance, or that's a very complicated phrase of basically saying that, the tumor has outsmarted the drug. So what are you going to do next? And why is the tumor outsmarting the drug? And what are the mutations at play? And what is happening? And there's a lot of science going into understanding mechanisms of resistance. And this is a long way of me answering the question, which is, once we start to understand the mechanisms of resistance, then we can develop these next generation drugs that work specifically against these resistant mutations. So you start with one oral therapy, taking something like ALK rearrangements. ALK rearrangements, generally you start with alectinib or brigatinib. You give the patient that drug, and hopefully they do well for a very long time. But if they don't and they develop cancer growth, this is where lorlatinib has really come into play, because we know lorlatinib is very active against one of the most common mutations that causes resistance to alectinib. So that is what is being applied across each gene. You start with the drug, but then when the drug stops working, you understand why it stopped working, and then you develop additional new agents against those resistant mechanisms. And so, yes, I think we will come to a point where it will all be about sequencing. I mean, that's the whole goal, is sequencing therapies. And I always tell patients, I go, what am I going to do next? And I say, we will probably move to this drug, but in 2 years, my answer is going to change, because there's going to be another drug that I don't even know right now.
That's
and
right.
that's it. You try to get the patient to the next new drug, and that has been the most rewarding part of this field for many of us who are involved in the research.
Yep.
Right. So one question just came in that I think is important. So I'm going to ask it now before we move on. At Johns Hopkins, do molecular pathologists and or interventional pulmonologists or anyone else have the ability to order this testing, or is it just the medical oncologist? Who can order these tests?
So we've set it up, and we didn't really talk about this, but we set up what's called reflexive testing. So essentially, any biopsy that's done that's a lung cancer, it automatically gets sent. And because we're all very busy and I'm sometimes lazy, we needed to set up a mechanism where, it was done automatically. And so any biopsy that's done where you have diagnosed a patient with non-small cell lung cancer, the pathologist automatically sends it for molecular testing. So it takes the onus off the oncologist, and it speeds up testing. So that, keep in mind, patients don't see me until after the biopsy. And sometimes they don't see me until 7 to 10 days after the biopsy if I'm busy. And if I see them in 7 days and they still haven't had the test ordered, you're talking about another 4 to 6 weeks. So we said, look, as soon as you get the biopsy, as soon as it's done, the pathologist send it off.
I think that's great. And I think it's so important. I can remember 10 years ago now, or 11 or 12, whenever, even EGFR was the only sort of player in the game, that wasn't even something that was reflex tested, right? And so the whole reflex testing has been a huge, huge conversation. I am beyond thrilled to hear that it's happening at your center, and I'm really keeping my fingers crossed that um, that it starts happening more often and everywhere. So with that,
Yeah.
what I want to jump into, because I do want to be mindful of time, and we may wind up going five or so minutes over. But we've talked about biomarker testing in the early part of this conversation. We talked about who typically would get tested, and it's typically the late stage patients who would have this testing. But some really exciting things came out at ASCO around the ADORA trial. And this is the biomarker testing in early stage patients. Can you talk a little bit about what the data is that's been coming out of this trial, what it currently means, but sort of, I guess, the footstep it is into this whole entire other space where we really are looking at this biomarker testing in the earlier stage patient where historically it wasn't done?
Yeah. So we know, just kind of create context, we know that in the EGFR world for advanced stage patients that a drug called osimertinib is the standard of care. And osimertinib has outperformed all other drugs in advanced stage disease for EGFR mutant lung cancer. And I guess the question is for this drug, as well as all other drugs that target specific mutation, is can we carry the information we've learned in the advanced stage and apply it to early stage that potentially can lead to more cures? And so, building on the science in the advanced stage setting, this was a trial that looked at patients that had removal of their tumor. So they were technically cured by surgery. So these are early stage patients who had disease confined to the lung or regional lymph nodes. The tumors were removed for curative intent. All of the tumors had EGFR mutations. And the standard of care for patients like this is generally chemotherapy. So the trial allowed physicians to deliver chemotherapy first for any patient they thought should get chemotherapy. Chemotherapy does improve survival. It improves survival based on the data anywhere from 5 to 15%, but we always offer it for any patient who's a stage 1B or higher. So in this trial, they did allow patients to receive chemotherapy for 4 cycles afterwards, and then patients were randomized to osimertinib versus placebo. And I talk about trials that don't have placebos, but remember, this study was designed, the placebo was the control arm, and that was the standard of care. I mean, that was really all there was. So the only way to definitively answer whether adding osimertinib after chemo, or for some patients didn't get chemo, did anything in terms of improved outcomes, you have to compare it to whatever the standard was and whatever the standard is, which is nothing right now. And what we saw was patients were allowed to receive osimertinib for up to 3 years. And so incredibly, the trial had to be stopped prematurely because the benefit was so great that they had to stop it. And the question that the trial was trying to ask was, patients who are EGFR mutated, who have surgically removed, that had their tumors removed, do they have any benefit in terms of outcome if you give 3 years of an oral targeted therapy? And impressively, there was a massive improvement in an endpoint called disease-free survival, which is basically a composite endpoint of either recurrence of disease or death. And what they saw essentially is that there was a huge benefit in disease-free survival, meaning patients who got osimertinib were much less likely to experience either recurrence or death. In fact, 83% less likely to experience recurrence or death versus receiving nothing, which again was the standard of care. I think because the magnitude was so significant, it took us all a little off guard. I think the data was going to be presented at ASCO, and we thought, gosh, is this going to be worth the change in practice? But I think seeing an 83% reduction in either recurrence or death in the osimertinib arm really warrants now a discussion about osimertinib. Now, that's the pros of the trial. The cons are the drug is costly, it is expensive, and there are people out there who say, well, we're not ready to use it until the FDA approves it. And as of August 2020, the FDA has not approved it. That said, I think the data is compelling enough that we need to have this discussion. And I think that it's really important also, this really tells us, you know what? An early stage lung cancer, we have to test. We do it at Hopkins for every patient, but every early stage patient also needs to be tested, because if you have an EGFR mutation and the chances of you having one based on the data is around 10 to 15%, you may be able to have a pill or receive a pill if you decide after chemotherapy for 3 years, which can potentially improve your outcome. Now, the trial did not look at overall survival. It looked only at disease-free survival, which more focuses on recurrence rather than death. So there are folks who say, well, we don't know if there's a survival advantage yet. But to me, the data is compelling enough that it is worth a discussion, and it is also underscoring the importance of genomic testing in early stage lung cancer.
Do you think, and then I want to switch to my mom about this, but do you think that we can expect to see similar studies happening with other biomarkers and other drugs?
Yeah, I think the other thing is this paved the way for other trial designs. And I think if we're not going to be doing this, then we have to do this because, again, it's great to use these drugs in the advanced stage setting, but to then apply the science to early stage that may lead to higher cure rates is where we have to head. And I'm passionate about that. And so I do think we will have other trials, specifically for ALK-rearranged lung cancer. We may have other trials looking at drugs prior to surgery. So the mutation up front, the patient is potentially surgically resectable, or you can remove it. And rather than do the surgery right away, give the targeted therapy first and then go on to surgery. And there's actually a cooperative group trial looking at this right now. So I think that we've learned too much in the advanced stage setting not to apply the science in the earlier stage settings. And I think this will improve the outcomes for our patients.
That's great. I want to switch to the pretty lady on your right on my screen, because I know she's got a lot to say about this trial and how excited she is and what this could potentially do for biomarker testing as a whole.
Yeah, because for many, many years, patients who discovered their cancer early, for whatever reason, whether they had CT screening or they found it accidentally, they were, referred to a surgeon, tumor or lobe removed, and told they're cured. Everything's good. We need to create a standard of care for these patients to let them know that, a good percentage of people that have surgery for early caught lung cancer recur, and it's a big group of patients. And, this trial is bringing this whole issue to light. And I'm personally very excited about it, because we have to work with all of these patients. And, I think it's criminal for a patient to be told they're cured only a year later to find out their cancer has come back.
Yeah, I would agree. And I think that's so important, Bonnie. As much as we've tried, and I mentioned, chemotherapy only does so much. And yes, we can cure patients with chemotherapy, but to have this therapy in our hands and be able to dispense it and potentially lead to cures is where we need to go. And for whatever it's worth, I've already, when I first saw the data, I was taken aback by how this can't be true. And then you digest it and you look at it and you talk about it with colleagues. And I've already offered it, and the drug is not yet approved. But for what it's worth, I'll put my nickel down. I've already delivered it to 3 patients. So I think that for the I say it's a discussion. Just because the discussion usually says, look, this drug's not approved yet, but and it may have some toxicities, but generally well tolerated. And if you or my mom or you or my family member, this is what I do. And if we can get you the drug, we'll do it. That's usually what I mean by the discussion. And I think that patients have been, for the most part, very receptive, and we've got it approved. It's taken a little work on with our team. It takes a village, right? I have a navigator and a social worker and a nurse practitioner. We've had programs on this, and they all help with not only getting the drug approved, but also delivery of drug, the teaching session about the drug, following up with the patient. So this is something also that we are really passionate about with what we do. It does take a village. It takes a team. It's not just me. That helps make this happen.
And the patient's part of the team. They're not
That's
just a
right.
patient all the
Well,
time. You know, they're
and a
out there
coach.
learning too, and they can be a big part of
Yeah.
bringing in new information that moves these things along faster.
Yeah.
This has been such a great discussion. I do want to be mindful of time. I know that it's after 9:30 p.m. out on your coast, Ben, so I want to be mindful of that. Before I do the final closing and housekeeping, I just wanted to see if either of you had any final thoughts, anything you wanted to say before we close out the meeting tonight.
Do I get to go first?
Sure.
Sure.
You're the star.
Testing.
Testing.
Don't get
Testing.
Be your own
Yes.
advocate. Ask for your reports. Send them our way. Send them to GoTo Foundation to figure. I mean, you gotta understand what. I can't tell you how many times I've run into patients where the molecular alteration was missed, but I would just make sure you get comprehensive genomic profiling done. We have too many drugs now available to deliver that outperform chemotherapy, that avert the need for radiation, improve quality of life. We really need everyone to be doing. There's so much confusion out there, so just really advocate for comprehensive genomic profiling, next generation sequencing.
Thank you. Testing. Love it. I can't say it enough.
I initially thought he was checking his mic.
Right.
No, I have this
Testing.
slide that I always present when I give a talk, and it's a slide of a group of Navy SEALs carrying one of their injured out of the warfield, and the caption is "Leave no gene behind." So leave
There you
no
go.
gene behind.
Gene
Make sure
behind.
you
I
look
love
at
that.
So
I love it.
Yeah.
that's
Love
my
it.
last parting shot.
I love it.
Awesome.
I love it.
Awesome.
So important. And for those of you out there who may be having trouble getting access to the testing, again, please call our helpline because we can help you, to try to gain access to that testing among the many other things that we do. So with that being said, I want to give a huge thank you to Dr. Benjamin Levy, who not only is someone that we go to consider to be a key opinion leader in this space, but a friend. So thank you so much for yet again coming out, participating in a living room, and help us to get the most important information out to the patients when they need it. This has been amazing. I want to give a huge shout out and thank you also to my mom, who came down and decided to join again. We figured it was safe enough as long as we were distance enough. So I'm thrilled to have her back on board with this. Of course, the housekeeping. Next living room is September 15th. Dr. Christine Lovely from Vanderbilt out there in Nashville is going to be joining us for a conversation. I'm happy to also say that Dr. Lovely also recently agreed to become the chair for our scientific leadership board. Our former chair had to resign due to a new job opportunity. So we are beyond thrilled to have Dr. Lovely to join us. So please tune in on September 15th for a conversation with her. As always, I want to talk about our fall events. As some of you may or may not know, our summer events, and since COVID, nobody can be together in person, but our events team has done an outstanding, stellar job putting together some of the most fun virtual events that I've witnessed, and we've searched a lot of them, since March. So our Houston virtual event is on September 12th. San Francisco, out here in our hometown, is on September 20th. Philadelphia is October 4th, and Hollywood, Florida is October 24th. So please, if you live there, if you know somebody that lives there that wants to participate, go to our website and check it out. Another fantastic program that our events team has put together is something called My Perfect Marathon. We formerly had a marathon program, but since marathons aren't going off right now, we were trying to figure out a way to make it fun. So the program's called My Perfect Marathon, launching this March for people who want to customize their own running experience. So again, please go back to our website and check that out. And our gala this year, which is really one of the most spectacular evenings I've ever been able to attend. We'll be having, it's our 15th gala this year. It's going to be on November 14th, also a virtual event. Stay tuned for a little teaser that's going to be going out to give you a sneak peek about what you might expect night of gala, but it promises to be a really great time. As always, for the latest news and most recent information on COVID and lung cancer and the joint statement that we put together with some of the other lung cancer groups around the country, please go to our website and look for that there too. And then I would be remiss if not in reminding folks to join the lung cancer registry. These patient-reported outcomes are so important to help complement some of the research that's being done, but also to maybe identify gaps in some research that needs to be done. So please consider going to the registry and joining that. Again, a huge thank you to Dr. Levy for coming out and talking with us tonight. To Peninsula Television and the folks on the back end that you aren't able to see who are helping make this all happen and bring it to you. A huge thank you to them. And then, of course, our supporters, our presenting sponsor this evening, Lilly Oncology. Thank you for constantly supporting not only, all of GoTo Foundation, but this Lung Cancer Living Room in particular. Thank you for recognizing its importance and value to our community. Also with special support from Blueprint Medicine, Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Foundation Medicine, Genentech, Jazz Pharmaceuticals, Lilly again, Merck, and Takeda for your constant support of the series as it evolves throughout the year. So with that, I'm going to say a lovely good night. Thank you all for joining, and we hope to see you next month.
Thanks for all.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.